Hello. So today we are going to discuss the important MCQ for public service commissions. These entire MCQs are taken from the all pharmacology topics, and it is all the concepts are very important regarding the MPSC point of view. So we are trying to cover all the concepts which are important regarding this exam. So first question is, in competitive receptor antagonism, agonist DRC shifted To which place? So first of all, we have to understand, we have to step by step break down this question. First is competitive receptor antagonism. What is a competitive receptor antagonism? We know there is a receptor. This receptor is the binding site for all the substrate. In the competitive receptor, there is a site which is available for the attachment of the substrate, and the enzyme can compete for the same position with the substrate. For this position, there is a competition. So in the competitive receptor antagonism, agonist shifted to which place of the DRC? What is DRC? DRC is the DRC is the dose response curve. What is dose response curve? It is the curve for the dose and the response. Suppose if we are going to plot a graph for the dose and the response of a drug, then if the dose is getting increased, then the response of the drug is also getting increased. That is why we will obtain a graph of a sigmoid shape. Whenever we are going to increase the dose, there is increase in the response. So with the dose, there is increase in the response. But at a point, there is a saturation point at which if you are going to increase the dose beyond this point, the response will going to be same. So if you are going to add a competitive receptor antagonism in this place, then also there is a increase in this response of the response regarding the dose of the drug. So as we are going to increase, there is increase in the response. If we are taking agonist and antagonist. So this plot is going to be shifted towards, there is a parallel plotting of the graph when we are going to plot this graph for the agonist as well as for the antagonist in respective to the agonist graph. So it is going to be in the parallel position. There is a parallel shift of the agonist DRC. And there is no suppression of the maximum response. Why? Because whenever we are going to increase the dose in the competition of this agonist, from the antagonist, we have to increase the dose of the drug so that it can compete with this situation. What does it mean? If there is competition between the agonist and the antagonist, then we have to increase the dose of we have to increase the concentration of the agonist. When this concentration of the agonist is more than the concentration of the antagonist, then there is same type of the graph will be seen, and this graph is similar to the agonist graph, but it is parallel, and there will be shifting of this graph from the agonist position. From the agonist position, this was there. And when we are going to add this competitive antagonist, there is a parallel shift of the graph of the DRC and no suppression of the maximum response. Like the maximum response that is seen in this case, the same maximum response can be seen in this case, but the dose should be higher than response to agonist. Because in case of the single agonist, it does not have any competition with others, so that how much agonist is available, that is going to give the response. But when the competition is present, competition with the antagonism is present, then they should increase their dose so that there should be a equilibrium between the agonist and the antagonist. Then we have to increase the dose of the agonist so that the agonistic response can be seen, and the maximum response which was seen with the agonist, that can be seen with this antagonist also. So the next question is in non-equilibrium type of enzyme inhibition for the drug action, what will affect on the Km and the Vmax? So first we have to understand what is Km, what is the Vmax. Km is the Michelson constant What does it mean? In this Michelson constant, it shows the affinity of the enzyme to the substrate. Affinity of the enzyme to the substrate. To which level? To that level that it should reach the half of maximum velocity. What does it mean? The Km is the affinity of the enzyme to the substrate. Suppose the Km, there is low Km. It means it require low concentration of the substrate to reach half of the maximum velocity. To reach half of the maximum velocity. Low Km means there is low concentration of the substrate. Low concentration of the substrate, lesser amount of the substrate is required to reach the half of the maximum velocity. It means the affinity for this is higher because low concentration of the substrate is able to give that velocity which is showing maximum affinity, which is showing increased affinity. So low Km means low concentration of the substrate to reach half of the max velocity. And the opposite is seen with the high Km. High Km means high concentration of the substrate is required to reach half of the maximum velocity. It means the affinity means the binding capacity. The binding is lesser with the high Km. So this is the meaning of this Km. And what does the mean of the Vmax? Vmax is the velocity, maximum velocity of the reaction. Now we'll come back to our question. In non-equilibrium type of enzyme inhibition. What is non-equilibrium? There are two types of enzyme inhibition can be seen. First is the equilibrium type. Second is the non-equilibrium type. When there is the equilibrium type of the enzyme inhibition, equilibrium means it is in the equilibrium. It can be reversed. It is not bonded with the, it is not bonded with the covalent, high covalent bonds. It means non-equilibrium means when it is binded with the irreversible type of binding, which cannot be reversed. It means the binding is covalent type. Strong binding is there. When there is a strong binding, what does it mean? There is a strong binding is there of enzyme to bind with the substrate. It means the low concentration of the substrate is able to achieve that maximum half of the maximum velocity. Now it is saying non-equilibrium type of enzyme inhibition. It is there is a inhibiting type of enzyme which is going to inhibit the reactions. When it is going to inhibit the reaction, it means the maximum velocity is going to be reduced. Because it is enzyme inhibitory type, it is going to inhibit the maximum velocity. So what will happen to the Km? The Km, the affinity, because it is non-equilibrium type, it is a high affinity. So the Km will remain unchanged. For which type of equilibrium? Non-equilibrium type of enzyme inhibition. Suppose it is the equilibrium type of enzyme inhibition. When there is the equilibrium type of enzyme inhibition is there, and in the equilibrium, we can have two type of enzyme inhibition. Equilibrium means it is a reversible type. When it is not bounded with the strong bond. So it can be a competitive type and it can be non-competitive type. Competition with the, it means whenever there is the receptor site, there are two type of sites are available. First is the substrate binding site, second is the allosteric site. Now, when the substrate is coming, when this agonist is coming, then the enzyme which is present, it is going to have the competition with the substrate for the same binding site, right? That is the competitive type. Second is the non-competitive type site. It means the substrate is going to bind on the substrate site, and the allosteric site, there is the binding of the enzymatic activity will be there. When this is going to have, when in the competitive site, whenever there is going to have the competition for the binding, whenever there is the competition of the binding, it means the higher concentration of the substrate will be required to attach to that binding surface of the receptor. It means the higher substrate will be required, means the Km will be high. Second, the non-competitive type. Non-competitive type, it does not have any competition for the binding to the substrate site. It means that Km, it will remains unchanged for the non-competitive type of equilibrium reaction. So what will happen to the Vmax? For the maximum velocity, when the higher concentration of the substrate is required to attach to that site, then the velocity of this reaction will be unchanged. Because higher concentration will be there will be the competition, and the velocity of the reaction will not be affected. But when there is the non-competitive side, there is no change in the affinity. It means the lower concentration will be sufficient to have the effect, so that it doesn't, what does it means? At the lower concentration, maximum velocity can be achieved. So the maximum velocity in case of the non-competitive type is the Vmax is decreased. So this is about the equilibrium type. We are talking about non-equilibrium in this question. Non-equilibrium means it is which type of this? It is irreversible. When it is irreversible, when it is not going to be reverse the reaction, then in this case, this Km, this affinity, it will remain unchanged, and the Vmax is the maximum velocity. It will require lesser for the reactions. So for this question, there is Km is unchanged and the Vmax is reduced. For equilibrium, there is competitive and non-competitive. For the competitive, there is Km is high and the Vmax is unchanged. For the non-competitive, Km is unchanged and Vmax is lower. Second question, next question, the mechanism responsible for the development of tolerance to the morphine. What is morphine? Morphine is a opioid. Morphine acts through the opioid receptors. There are different type of opioid receptors. There can be mu, there can be kappa, there can be delta. Now, mostly they have the affinity for the mu receptor, lesser affinity for the kappa and the delta receptor. Now, the question is, for the development of tolerance. Tolerance, how the tolerance will develop? When the receptor becomes a desensitized. When the receptor becomes desensitized, then there will be the tolerance can be seen. What does the mean of the tolerance? Tolerance means when the little dose is effective, when previously the dose which was effective for producing the effect, now because of the changes in the body, because of the changes in the structure, there is that particular dose is not effective for producing the effect. So in case of the morphine, if the tolerance develop, it develop because of this opioid receptors, they have become desensitized to it or down regulated as this. Then this receptor type of the mechanism is called the cellular mechanism. So there will be the cellular type of the tolerance will be seen in this case. Not enzyme mediated, not polymorphism, no, not drug disposition. The cellular type of mechanism. Now, which of the NSAID is safest in asthmatic patients? NSAID safest. Now, we have to see safest for the asthma. What is asthma? Asthma is a condition in which there is the bronchoconstriction in the person. So that because of that, there is difficulty in the breathing. And what is the mechanism of action of the aspirin? Aspirin is going to inhibit the COX enzyme. Because of the inhibition of the COX enzyme, prostaglandin is decreased. And we know the mechanism of action of this COX. That COX enzyme, it is formed by the arachidonic acid. Now, this arachidonic acid, which is present in the plasma membranes, phospholipids, plasma membrane, which is made up of the phospholipid. It has this 20 carbon structure, which is called the arachidonic acid. Now, this arachidonic acid can be acted on the cyclooxygenase enzyme or the lipooxygenase enzyme. Cyclooxygenase enzyme, it leads to the prostaglandin synthesis. So, because of this asthma, there is already lipoxygenase enzyme is increased because the leukotrienes are the inflammatory mediators which are secreted during the asthma. If we are going to inhibit this prostaglandin, the COX enzyme is inhibited, then this lipooxygenase enzyme is going to be increased. So in that case, it will cause more bronchoconstriction to the person. So in that case, we have to give those COX enzyme, if we want to give, that does not block both the COX enzyme. COX enzyme is available in two forms, COX-1 and COX-2. COX-1 is present in all the physiological structures, and COX-2 that is present in case of the pathological things, in case of any pathology it is present. Then this COX and this COX-2 enzymes, we want there is the lesser suppression of this COX-1 and COX-2. In case of aspirin, it is non-selective type. It is going to have the effect on both COX-1 and COX-2. Endomethacin, it is also non-selective type of NSAID, so it is going to block COX-1 and COX-2. Nemoslide is a preferential COX-2. Preferential COX-2 means it is going to have 90% effect on the 80 to 90% effect on the COX-2 and 10 to 20% effect on the COX-1. So it means it is going to have mostly on the COX-2 effect. The COX-1 is free. And ibuprofen, again, this ibuprofen so this ibuprofen, this is again, it is COX-2, it is also non-selective type. Because of this non-selective type, it is also going to have the effect of, it is going to increase the inflammatory mediator. So in that case, the safest one is the Nemoslide, which is preferentially COX-2. Next question. Next question is saying the recommended dose of quantity of 0.2% of chlorhexidine as a mouthwash. What is the recommended quantity of chlorhexidine mouthwash? Recommended is the 10 to 15 ml of the chlorhexidine is recommended for the action. But it is seen, if we want to be a little more precise, then this 10 ml of this chlorhexidine is considered to be the more precise. And this 10 ml of the chlorhexidine as a mouthwash, it is given for 30 seconds. Why it is given for the 30 seconds? Because of this 30 seconds So because of this recommended quantity, chlorhexidine, it is given 10 ml. It is sufficient. And if we want to choose between 10 to 15 ml, then 10 ml is the sufficient one, and it should be given for the 30 seconds only, not more than 30 seconds, because the chlorhexidine has the tendency to deposit on the tooth surface. That is why it can cause the staining of the teeth. uh, that is why it is not preferred more than 30 seconds के लिए it should not be given. Next is the drug causing hypocalcemia. Drug which are going to decrease the calcium level in the body. Drug which are going to decrease the calcium level in the body. Uh, there are several drugs which are going to decrease the calcium level in the body. First, we can see the two drugs which are most important to decrease the calcium level in the body. We can remember this two drugs by the name loop drugs. Loop uh, and P loop P drugs are drugs which are going to decrease the calcium level in the body. What is loop? Loop is the diuretic. Loop is the diuretics. Loop diuretics like furosemide, torsemide. These are the drugs which are going to increase the excretion of the calcium, which are going to increase the excretion of the calcium from the body. Loop diuretics, it is going to increase the excretion of the calcium from the body. When the calcium excretion is increased, it means there is hypocalcemia. Similar effect is seen with this phenytoin. What is phenytoin? Phenytoin is the anti-epileptic drug, and this phenytoin, it also reduces the calcium metabolism, because this calcium has the effects on the vitamin D. This calcium has the effect on vitamin D metabolism, vitamin D absorption. When the vitamin D is lesser absorbed, then the calcium is also decreased in the body. So hypocalcemia is produced by the phenytoin, and among all of them. If we want to see which other drug produces the hypocalcemia, then the drugs like loop diuretics produces the hypocalcemia. Then this drug called thiazide. Thiazides is also diuretic drug, but it is that drug which will increase the calcium level in the body. It is a hypercalcemic drug, because it does not allow the excretion of the calcium, so there will be the hypercalcemia with this. Then there is a drug called lithium. Lithium is the anti-maniac drug, or the drug which is used for the bipolar disorder. This drug is going to stimulate the PTH hormone. Now, PTH hormone, whenever in the body PTH hormone is there, this PTH hormone is going to have the effect called the hypocalcemic effect is seen. It is going to decrease the blood calcium level. How it is going to decrease the blood calcium level? It can decrease the blood calcium level by three things. Either it can it can take the it is going to PTH is always stimulated whenever there is hypocalcemia in the body. Whenever the hypocalcemia is there, then this PTH is secreted. Now this PTH, whenever there is PTH is there, PTH is going to produce the effect called hypercalcemia. It is going to increase the calcium level in the body. How it is going to increase? They can take the calcium from the bone. They reduces the excretion of the calcium. They reduces the excretion of the calcium. Third things, they will increase the intestinal absorption of calcium. By this way, it is going to increase the calcium level in the body, and produce the effects called hypercalcemia. So, in among all, the phenytoin is the drug which will have the effects like hypocalcemia. Apart from phenytoin, we can take the drug like loop diuretic furosemide as the drug which will produce the hypercalcemia. Physical dependence of the drug. There can be the two types of the dependence for the drugs. Can be the psychological dependence, and uh, there can be the physical dependence, the psychological and the physical dependence. Most of the drugs produces the psychological dependence, like the caffeine. We drink caffeine in the form of coffee, in the form of tea, and it does not produce the psychological dependence. It does not produce the physical dependence. We drink it because of the psychological sufficiency. If we don't drink, there is no physical harmness is there. We can feel the restlessness, we can feel the headache, but the physical dependence is not there. If someone wants to quit the caffeine, they can. There is no withdrawal symptoms of that. Second is the amphetamine. What is amphetamine? Amphetamine is a CNS stimulant drug which will norepinephrine reuptake inhibitor होती है, which is going to increase the norepinephrine content in the body. When there is an increase in the norepinephrine, whenever there is increase in the norepinephrine, so it will give the several effects in the body. Third is the pethidine. What is pethidine? Pethidine is a type of opioid. Pethidine is a opioid. Pethidine is a opioid type of drug which will have the effects in the body. But this opioid works through the opioid receptor. And whenever the receptors are involved, they are going to have the physical dependence. There will be the withdrawal symptoms if this is not taken. The cocaine, it does not act through any receptors. It does not produce the physical dependence. It will show the psychological dependence. So the opioid, it shows because of the opioid receptors involved, they shows the physical dependence. Now, psychotropic drugs. The psychotropic drugs are the antipsychotic drugs which is taken to treat the psychotic conditions. Like chlorpromazine, prochlorperazine, haloperidol, haloperidol. So these drugs are going to have the effect on dopamine receptors. They are going to decrease this dopamine level, D2 receptor. They are going to block this D2 receptors. Because of the decrease in this D2 receptors, because of this decrease in this D2 receptor, there is a reversible type of, there is a dopamine is irreversibly proportional to the prolactin. If the dopamine is reduced, what does it mean? If dopamine is reduced, it means because the prolactin is irreversibly proportional to the dopamine. Because of this, dopamine is decreased, prolactin is increased, and prolactin is responsible for the production of the milk. So there will be the gynecomastia, and the release of the milk will be there. There will be the galactoria. Gynecomastia is the increase in the size of the breast. Galactoria is the release of the milk. So both the symptoms will be seen in the person who is taking the antipsychotic drugs for a long period of the time. Which drug in the following is a mitotic inhibitor which binds to the microtubular protein tubulin? Cyclophosphamide, methotrexate, cisplatin, and vincristine. The drug cyclophosphamide, it is a anti-immunity drug. It is a autoimmune disorders. For the autoimmune disorders, we can use this drug, cyclophosphamide. Second is the methotrexate. It is also a drug which is a immunosuppressant drug. Cyclophosphamide, methotrexate, both are immunosuppressant drugs. And immunosuppressant drugs which are going to decrease the immunity. Second is the cisplatin. Cisplatin is the anti-neoplastic drug which are going to decrease the neoplasia in the body. All these drugs act through the DNA. It will prevent the DNA cross-linking. So there is another drug called vincristine. Vincristine is a drug which is seen. It acts on the nicotinic receptors and acts through the microtubular protein tubulin. And it will inhibit the mitotic reaction in between. So that is why this can be used. The next question is, which among the following is an inotropic receptor? Inotropic, it means in which the ions are involved. Dopamine receptor, D1 receptor, it is which type of receptor? It is a type of G protein coupled receptor, especially GQ type. Muscarinic receptor is also GPCR, which are going through the GPCR, and the different variety of M1, M2, M3, M4, M5, and this M1, M2, M3, M4, M5, they work through the different types of GPCR. Like M1 and M3 are GQ type, and M2 is GI or GO type. D2 dopamine receptor, it again works through the GPCR. Now there is another receptor which is called the GABA receptor. What is the GABA receptor? GABA receptor, if we look the structure of this GABA receptor, it is a like a pentameric structure in which has 2 alpha, 1 beta, 1 delta, and 1 gamma cell. And in this whole structure, there is a flower-like structure is there, like the sunflower. In the between of this black portion which is there in the sunflower, in that structure there is a channel. Ions are present, chloride channels are there. Because of the opening of the chloride channel, the action occurs. So this type of the channel is seen in the benzodiazepine receptor and the GABA receptors. So the GABA receptor is the only which has the ionic component. So it is the inotropic receptors. Next is the therapeutic index. What is therapeutic index? Therapeutic index express the safety margin of the drug. How much the drug is safer for the person. Therapeutic index can be calculated by LD50 by ED50. What is LD50? L means lethal dose. E means effective dose. And what does the mean of 50? 50 means that dose which is required to kill 50% of the population, then it means it is a lethal dose. Suppose if we are taking a drug A is taken into the 10 milligram of the concentration, it is given to the 100 people. If this 10 milligram drug, when it is taken by the 100 people, the 50% died. It means this 10 milligram concentration is lethal dose for the 50% of the population. Then it is called LD50. Second, effective dose, when this 10 milligram of the drug is producing the effect in the 50% out of 100, then this is called the effective dose. When it is producing the effect in the 50% of the population, then it is the effective drug. And the ratio of the LD50 by ED50 is called the therapeutic index, and which tells about the safety margin of the drug. If the therapeutic index is low, it means the drug is not safe for the person. They can produce any kind of toxicity in the person. If the therapeutic index is high, it means this drug is safer. If the therapeutic index high, it means safer drug. Chances of the toxicity are lesser. Next question, acute development of the tolerance after rapid and repeated administration of the drug at the shorter interval is called whenever we are going to give the repeated dosing at the regular interval, then there is the development of the tolerance because of that because the receptor in that area become desensitized, or they can be down regulated because of that higher amount of the or the repeated succession of the dosing. So this is called the tachyphylaxis. Idiosyncrasy means whenever the toxicity, whenever the tolerance is there because of the genetic reason, then it is called the idiosyncrasy. Cross tolerance means when the person is tolerant to whole class of the drug. Suppose if a person is taking, a person is tolerant to uh, alcohol, then there is a chances in that alcohol they can be tolerant to the general anesthesia also. So highly alcoholic person, chronic alcoholic person is usually lesser sensitive to the general anesthesia because of the development of cross tolerance. Metabolic tolerance, because of the metabolism in the body, the development of the tolerance because of the presence of the drug all the time in that area. So there is the tolerances developed. Now, the next question. In the clinical trial, pharmacological evaluation of a new drug preferred healthy volunteers. What is the clinical trial? Whenever there is a making of a new drug, there are five type of the trials are implicated. First, and the newest trial is called phase zero trial. Phase zero means it is called the microdosing. The dosing which we have seen in the animal, less than that dose, we are going to give that dose to the person, to the healthy individual, to see the effects, adverse effects of the drug. But some of the scientists does not approve this concept because we are giving so much lesser dose, 1/10 or the 1/100th of the dose of the required, then the adverse effects will not be visible. So some will not accept this phase zero, but some countries accept the phase zero in the clinical trial. Second phase or the first phase is the phase one. Phase one is called the human pharmacology and the safety phase, in which the safety of the drug is seen. Human pharmacology and safety. So this type of phase, trial phase, it is seen in the healthy volunteers who wants to see the effects of the drug to upon themselves, on their bodies. That is phase one. Second is the phase two. Phase two means Phase 2 means when we are going to see this effect on the patients. This phase is called therapeutic exploration and dose ranging. And dose ranging. We are going to see the effects of the variable dose in the patients of that particular disease, for which we are going to for which we are developing the new drug. Third is called, after the therapeutic exploration and dose ranging, we are confirmed with the dose, then there is therapeutic confirmation of the dose. How much dose is necessary for that particular condition. And last is the phase 4, which is called the post-marketing surveillance. After the phase 3, the permission of marketing of the drug is available. If the permission is granted and the sufficient results are seen, then the phase 4 occurs. In the phase 4, there is the post-marketing surveillance. When that drug is available in the market, then we ask the doctors or the patient to give all the adverse effects they are feeling after taking that drug, and we will record that whole thing, and the surveillance is done under the pharmacovigilance program. What is pharmacovigilance? Pharmacovigilance is the new program which is launched by uh, various countries for the, it is the science and art of detection, assessment, understanding, and prevention of the drug related adverse effect in the body. So the pharmacovigilance is a science and art of detection, assessment, understanding, and prevention. Detection, assessment, understanding, and prevention, they all are the four components of pharmacovigilance program. It is the program which is conducted under this is called PVPI, Pharmacovigilance Program of India. Okay. For this question, healthy volunteers, they are seen with the phase 1, which is human pharmacology and the safety. Alcoholic extracts of the plants, drugs. Alcoholic extracts are seen in case of tinctures, like the tincture iodine is seen the alcoholic content. It is the 80% of the alcoholic content is seen with the tinctures. Elixirs, they also they are the viscous liquids which are used to treat the conditions, but they does not contain alcohol in a higher amount, and they are not obtained from the plant, so they are elixirs. Emulsions, when the two liquids are mixed, like which are not going to be mixed properly, there is a emulsification is there, like the oil and water or the water in oil conditions, they are emulsion. And the linctus is also sugary viscous drug which is usually taken for the treatment of cough. Angiotensin converting enzyme inhibitor, ACE inhibitor. ACE inhibitors are the angiotensin converting enzyme inhibitors which are used in various conditions like hypertension, like angina pectoris, like in case of CHF, they can be taken in myocardial infarction, they can be taken. And these drugs are captopril, enalapril, and they are usually the pro type of the drug. They have to be converted into the active form inside the body, and they produces a number of adverse effects. The most common, the most unique adverse effects which is created by ACE inhibitor is the dry cough, because it leads to the degradation of the bradykinin. Bradykinin, degradation of the bradykinin leads to dry cough. Apart from the dry cough, the other adverse effect is the hyperkalemia, angioedema, and dysgeusia. These all are the adverse effect which is seen with the ACE inhibitors. And hyponatremia is not seen. The main adverse effect dry cough is there, and to overcome this, the new drugs which are formed are ARDs, angiotensin receptor blockers. The name of angiotensin receptor blockers which are given is the losartan and telmisartan. Losartan and telmisartan is the angiotensin receptor blockers. They are angiotensin receptor blockers. Next question. Is the metronidazole, what is metronidazole? It is the antimicrobial drug. This antimicrobial drug is usually effective for number of infections, especially it is effective for the gram-negative or the anaerobe type of infections. The metronidazole, one of the important point about the metronidazole that it shows the disulfiram-like reactions. Whenever the metronidazole is taken with alcohol, after alcohol, or the pre-alcohol, before the degradation of the alcohol, then it will produce the effects which is distressing for the person, and they can have the number of distressing symptoms. This metronidazole can penetrate the breast milk, then they can penetrate the placenta, they can penetrate the seminal fluids, but they cannot penetrate the saliva. So the answer is this, and it's not, because they can penetrate the all situations, so it should not be given to the pregnant and the lactating mothers. Next question is the adverse effects of the thiazide include. We have seen in the earlier question, thiazide is a diuretic. It produces a number of adverse effects. In the most common adverse effects which is seen with the thiazide is the hypercalcemia. Hypercalcemia, but hypokalemia, hyponatremia, everything apart from calcium, it is excreted by the thiazide, but this calcium, it is not excreted. It means it is going to stay in the body and it produces the hypercalcemia. Hypocalcemia producing diuretic is only loop diuretics. Characteristics of tramadol. What is tramadol? Tramadol is the opioid type of painkiller which is given to treat the pain condition, analgesic conditions. This is it does not bind very strongly with the new receptor, but it has some partial agonistic activity on the new receptors. It is a partial agonist to the new receptors. New is the opioid receptor. So strong opioid receptor antagonist, no, it is a agonist. Not metabolized by the liver. Yes, it is metabolized by the liver by the cytochrome enzymes. It is metabolized, so it is wrong. More effective in the racemic mixture than the enantiomer. Yes, its racemic mixture is more effective than the enantiomer. Not reduce the seizures threshold. No, it reduces the seizures threshold. So the answer is C. Next is the which of the following do not suppress the gastric acid secretion? Gastric acid secretion. Gastric acid secretion is required in case of the ulcers. We want to suppress this gastric acid secretion. There are a number of drugs which are used for this. First is the H2 blocker. H2 blocker was the first drug which was used for this purpose to reduce the gastric acid secretion, like famotidine, ranitidine, cimetidine. These are the drugs which were used for this purpose. Second category of the drug which is seen is the PPI, proton pump inhibitor. Proton pump inhibitor like pantoprazole, omeprazole, and rabeprazole. These are the drugs for use. Third type of the drug which are going to reduce the gastric acid secretions are the anticholinergic drugs, because anticholinergic drugs are going to reduce the secretions in the body. So the drugs like prinzapine. Prinzapine is the anticholinergic drug. Second type of the drugs which can be used to reduce the gastric acid secretions, they does not reduce the gastric acid secretion, just the neutralize the gastric acid is the antacids. So then we are left with the sucralfate. What is sucralfate? Sucralfate is the ulcer protective drug which are given to the ulcer patients to protect the ulcer so that there is no burning sensation or the leaching of the ulcer content into the area. So ulcer protective drug sucralfate or colloidal bismuth substrate is given. Next question, it is a basic question. Calcium is absorbed from which part of the body? The mainly it is absorbed from the duodenum and the first part of the jejunum. But if you want to compare in between, duodenum is the most 90% of the calcium is absorbed by duodenum. Which of the following analgesic cannot be given in head injury patient? Head injury. In cases of the head injury, there is increase in the intracranial pressure because of the increase in the carbon dioxide in the brain. So in that case, which drug we cannot give? We cannot give the opioids. Opioids are going to increase the intracranial pressure. That is why opioids are not given. Apart from this, what are the other contraindications of the opioids? Opioids should not be given to those persons who are already in the respiratory distress, because opioid, it produces respiratory distress, and most of the opioid addicts die because of this respiratory failure. Which of the which of the following LA does not cause vasodilation? Most of the LAs are vasodilators. That is why we are using vasoconstrictors with this LA. LA के साथ we are going to add this vasoconstrictor with the LA. The name of the vasoconstrictor which we add is the adrenaline, because LA itself is a vasodilator. So we have to add the vasoconstrictor adrenaline. Apart from cocaine. Cocaine itself is a vasodilator. It does not require any, it is not a vasodilator, it is a vasoconstrictor. Because of that, it has the respiratory distress functions. And we are not going to use, we are no longer using this cocaine for the local anesthetic purpose. Which of the following penicillin has anti-pseudomonas activity? Penicillin is an antimicrobial drug which is given. This penicillin is going to act in the body by the penicillin ring, and some of the bacteria produces penicillinase. Because of that, this penicillin's effect is not there in that person. So to overcome the situation, we usually add the beta-lactamase to that. Beta-lactamase is added. Beta-lactamase, like the amoxicillin, is the penicillin which is taken, and the beta-lactamase which is added with the beta-lactamase which is added beta-lactamase which we are going to add with this penicillin is the amoxicillin. We are going to add amoxicillin with clavulanic acid, and it is effective for most of the gram-positive and the aerobes type of bacteria. It has lesser affinity for the pseudomonas. So for the pseudomonas, which is seen with the hospital-acquired infections, that is seen in case of the pseudomonas, we give this piperacillin. This piperacillin is the extended spectrum penicillin, and to increase its affinity, to increase its efficacy, we are going to add some beta-lactamase with this. We are going to add tazobactam, like we are adding amoxicillin with the clavulanic acid, because both has the similar pharmacokinetic property. So we are going to add penicillin, piperacillin, extended spectrum penicillin, piperacillin with tazobactam, which is a beta-lactamase inhibitor, to increase its efficacy. Next question, which of the following drugs cause bone marrow aplasia except? Bone marrow aplasia is seen with the phenylbutazone, alpha-methyl hydroxytone, chloramphenicol, but it is not seen with the methicillin. Methicillin is a penicillin. Chloramphenicol is the chloramphenicol category. Phenylbutazone is an anti-epileptic drug. Alpha-methyl hydroxytone is also anti-epileptic. So this methicillin does not produce the bone marrow aplasia. Which of the following statement is correct about a highly ionized drug? Highly ionized. If we know for the absorption of the drug, we require two things. First is the unionization, and second is the lipid solubility. So the question is, if the drug is highly ionized, then which statement is correct? If it is highly ionized, then it will not accumulate in the cellular lipid because unionized drug will accumulate. It can easily cross the placental barrier. It can cross easily the placental barrier. No, it cannot cross because the lipid solubility is lesser. Unionized drug will cross. It is excreted mainly by the kidney. Yes, it is excreted mainly by the kidney because it is lipid. It is less lipid soluble. It is going to be excreted by the body. If it is lipid soluble or the unionized type, then it is going to be absorbed from the intestine. So because it is highly ionized, it is not going to be absorbed. So it will excrete by the kidney. It is the correct statement. Okay, there are the drugs which changes their kinetics from first order to the zero order. This is very important concept to understand what is the first order kinetics and what is the zero order kinetics. Most of the drugs follows the first order kinetics. First order kinetics means a constant fraction of the drug is eliminated every time when we are going to increase the concentration of the drug. Suppose concentration of the drug is getting increased by 10%, then the elimination will be the similar. Concentration of the drug is going is proportional to the elimination of the drug. If a drug was initially the concentration of the drug was 100. If the concentration of the drug was 100, then a constant fraction of 10% is going to be eliminated, means 10 milligram of the drug was getting eliminated. Now we have raised the concentration of the drug to 110, then the 10% of the concentration, it means 11 mg of the drug will be eliminated. If the concentration is increased to 120, then the elimination will be 12. It means a constant fraction of the drug is getting eliminated. How the concentration of the drug is increasing, elimination is also getting increases. That is first order kinetics. Most of the drugs will follow the first order. Second type of the reaction is the zero order kinetic. It means the constant amount of the drug is going to be eliminated. It is irrespective of the concentration of the drug. If the concentration of the drug is 100, 10 mg of the drug was getting eliminated. If the concentration is 110, constant amount, 10 mg of the drug is getting eliminated. If it is getting increased to 120, constant amount is getting eliminated. It means there is a constant amount of the drug is getting eliminated in case of the zero order reaction. So what does it mean? We have to inspect this drug every time because the amount of the drug which is getting eliminated is less. It is getting accumulated in the body. This is zero order kinetics. The drugs like alcohol follows the zero order kinetics. And there are special types of the drugs which initially follow the first order kinetics. But when the concentration of the drug is getting increased, that time it changes its kinetics to the zero order kinetics. From first order kinetics to change the kinetics to the zero order kinetics because of the increased concentration of the drugs. There are some special drugs like phenytoin, which changes its concentration, which changes its elimination from first to the zero order kinetics, and the theophylline. Theophylline is also changes its kinetic with the concentration of the drug. So for those drugs, we have to continue monitor the drug so that we should have an idea that how much amount of the drug is getting eliminated in the body and how much amount is getting accumulated in the body. So drugs like phenytoin, theophylline, warfarin, it shows changes its kinetics from first order to the zero order as the dose is increased. So that is why it is called Michelson-Menten reaction when the elimination kinetics is getting changed. So last question which we are going to take in this class is, which of the antihypertensive drugs are safe for the pregnant female? For the pregnant female, we can remember the antihypertensive drugs which can be used is mama needs healthy neonates. And methyl dopa is the safe for pregnant female. And is the nifedipine, which is safer for the female. H. Hydrazine is safer for the low neonates. So, and lebitalol, which is alpha and the beta blocker, are the safer for the pregnant female. It means four types of the drugs can be given to the pregnant female. Antihypertensive, four type of the drug we can give. First is the alpha methyl dopa, which will act centrally. Second is the hydrolysine, which is a vasodilator, can be given. Third, calcium channel blocker, nifedipine, can be given. And the fourth, alpha and the beta blocker, combination of alpha and beta blocker, labetalol, is the safer for the mother. So what drug cannot be given to the pregnant female? There are ACE inhibitors, which cannot be given. ARBs cannot be given. Direct renin inhibitors cannot be given. Direct ACE inhibitors like captopril and enalapril cannot be given. ARBs like losartan, telmisartan cannot be given. Direct renin inhibitor like eliscarine cannot be given. So in this question, enalapril is the correct answer. Nifedipine, methyl dopa, and lebetalol can be given. That's all for this class. I hope you understood the concepts which were important regarding exam point of view. Thank you so much for the class.